Welcome back. We're doing part two of pain management, dealing with off the couch and back to work, looking at the impact of psychological services. And this half, we're going to be talking much more about assessment issues and wrapping up some issues regarding workers' comp cases, getting folks back to work, and issues that we can help with. So looking at assessment therapy, something that we probably need to do more of and a better job at. But there are definitely tools that we can use that are fairly quick and easy that, if nothing else, can give us some ideas and discussion points that we can then use to launch with patients. So mental health professionals, really with a broad brushstroke, including rehab professionals through psychologists, social workers, etc., can use many of these kind of off-the-shelf screening instruments. Gives you a nice again, talking point, way to follow up with patients, all the way through simple kind of templates, ways to go that way, through more detailed screening instruments, such as the SCID, which is actually the Structured Clinical Interview for DSM. And that's actually usually provided by a psychologist or psychiatrist. Now, assessment can also focus solely on just what's going on psychologically with them. We can also tap into some personality variables to see what's going on. Also looking at things like addiction behaviors, etc., and tailor it to the patient we have, the problems that we're seeing, and again, as mentioned in part one, how can we help take that problematic core 10 to 20% that don't return to work and hopefully intervene sooner, identify them, and see if we can get them back on track. Now, one of the things you may be familiar with is the Job Satisfaction Survey. And just as a quick overview, I'll show it to you in a moment, just for reference, but it's easily obtained. It's a 36-item scale designed to assess employee attitudes about their job and sub-aspects that go along with their occupation. Now, each of the 9 areas has 4 items and used to make a total scale, so it's something that can be done easily and even added up in the office right after they take it. It gives you a summated or a total score, and basically everybody is rating from strongly disagree to strongly agree. We've all seen these kinds of scales. They're pretty standard, and most patients have seen them as well, so it's fairly easy for them to understand and to help out with it. Now, the Job Satisfaction Survey, like many of our tools, started life with other purposes in mind. It was actually created for human service organizations, to do HR, do employee screening, satisfaction, etc. But it does have some utility and some research background for these types of things like pain management, getting people back to work. Now, this is going to be probably maybe a little bit difficult for you to read, but at least you can see the format and what these things look like. They have very simple statements on them, the first one being, I feel I'm being paid a fair amount for the job, for the work I do. So, you can answer that for yourselves, and your patients will as well. And goes right down through. It's basically a 2-page item. The second page is a little bigger, but still probably a little too small for you to read. But goes on to other things like, I have too much to do at work. I enjoy my coworkers. All the way through, I like my supervisor. And so, again, these are some of those subcategories and aspects of occupation that it'll hit. And also will give you a nice overview of whether or not we have some barriers that maybe haven't shown through yet, and maybe some problem areas we can talk about and do some education with our clients. Now, depression and pain. Depression is something that is very real with chronic pain patients. We've talked about that a little bit in part one. And anywhere from, depending on the studies you read, from 30 to 50% may have some issues with a clinical depression. And this is compared to approximately 5% of the non-pain population. Now, if you remember back, what we know about depression in society is that it's usually about a 2-to-1 ratio, whereas women are more prone to have problems with depression than men, at least for clinical diagnoses and what we pick up. Now, when we talk about pain patients, I like to say that pain is the great equalizer. When we look at depression, we do not see gender differences. there's equal amounts of men and women who deal with issues of depression. And so outside of the normal population, many more patients will have it, and again, gender will not necessarily play a dividing issue. Now, in a study of patients, you can see the next point of patients with no mental health history who had an acute injury. This is before it really develops into a chronic pain syndrome. By the time it becomes, it kind of meets the rigid definition of chronic pain, when we start looking at a little later down the road, within 6 weeks, 42% end up going on to have problems. And so you can see physiologically we see changes, mood, life, etc. It all rolls together. And so that study by Carroll et al. Really just gives us that insight that you might have somebody living a whatever life, they have a triggering event within 6 weeks or so. If we don't intervene, we don't do something to help them, chances are a little less than half may go on to develop some very severe problems in looking at depression. Now, elsewhere I've talked a little bit about a depression scale called the Zung. The Zung is actually a nice, brief 20-item scale for screening global depression. It's fairly useful in the sense that it has much of the research in medically ill populations. Many of you know the Beck Depression Inventory. That gets used quite a bit. The Zung has also a long history. And the other thing that's nice about it is that, unlike some of the others, we have worked to create a brief Zung which takes out all the somatic items. And when we had talked about cancer and now talking about pain, one of the things that's very important in the medically ill is not judging mood symptoms and things like depression based off of something that might be part of their illness. And so if you have a pain patient, they may look depressed, may not be depressed. So we have to be able to eliminate some of the somatic complaints. Now also on the Zung, we're all busy, we're all pressed for time. One of the things that's nice about it is there is research out that looks at single items that can be used as screens in and of themselves. So while it is a 20-item, very short depression screen for major depression, we also look at things like fatigue, perceptions of cognitive dysfunction, insomnia, etc. So some of them there is research to back up that these things can be used. And as we're all busy, it's nice to have one scale that could do a number of jobs for us. Now, on the screen again is the Zung, fairly small for you to see, but again it's available and you can get copies of it. But starts right off with things like I feel downhearted, blue, and sad. And this one uses a very simple checkbox, whether it's none or little of the time, some of the time, good part, or most or all the time. Now, should you ever be in a situation where you're using this with patients, consulting, looking at these kind of records, etc., item 19 says that I feel that others would be better off if I were dead. And this is one that many times you'd think, well, who's going to answer that? And partly, if we take the time to assess patients, we do find they'll tell us a great many things that we never thought they would have admitted to or talked about. And this one is always a good screen for suicidality. As people have their lives really kind of put on hold and take a big hit, it's not uncommon, along with depression, to have it also include suicidal ideation. Feelings that I'll never get better, I'll never be who I was, my marriage is going to fall apart, other things are going bad, I just don't want to be here anymore. And so that's always one that needs serious attention should you use scales like this or others. If you find people saying, yep, that's me, we need to make a referral. And so those things do happen and do go hand in hand with some issues of pain. Now, catastrophizing is also a very important part of assessment when we look at pain patients. Catastrophizing really looks at a subset of depression and might be part of a depression, or it might be a kind of a sole entity that goes in patients who don't meet full criteria. So they're basically automatic thoughts, and we know what that can do to us when we have this constant conversation in the back of our heads. Sometimes people beat themselves up and get into a situation where everything gets blown out of proportion, versus what the reality is. So these automatic thoughts arise when they're not even really thinking about them. And so we want to be able to look at those and how they affect patients. In 1995, Sullivan and colleagues came up with this pain catastrophizing scale. And it really kind of solidifies three areas that are important to realize how does the patient view themselves and their situation. The first area is magnification. So are they exaggerating the threat of what the pain is doing to them? So, I have here the quote of, I wonder if whether something serious may happen. So if they magnify the pain, they're always looking at how this is affecting them, how it's impacting them. Ruminating, obviously if we ruminate on things, people spend a great deal of time focused on it, that they can't keep their mind off of their pain. And so it's hard to kind of let go and to get re-engaged in life if you're always thinking that the disability of pain is obviously being magnified in the first case, so all your time is spent on it, you're ruminating on it, you get stuck in that cycle again, and patients don't move forward. And finally, the sense of helplessness, which is really a pessimistic appraisal saying, there's nothing I can do, I'm not really part of this, I'm never going to get better, everything is bad. And we see many patients go through this, and definitely it's something if we see, we need to be able to make some recommendations and at least get them moved on towards somebody who can help identify and treat those issues. Now, this is, again, similar to the other instruments I've shown you. These are widely available, and this one works on the same kind of a checkbox issue. And again, the reason for even showing you these is to see that they don't have to be in-depth, they don't have to be long batteries of tests that are going to take up hours of time. Those have a place, and we need to do that. But if we have limited time and want to get a very thumbnail sketch of our patients, these things can help us and can give us talking points. Some of the items on there say things like, I feel I can't go on. And is that me? Not at all the way through all the time. And just general statements. I feel I can't stand it anymore. Well, if you have patients who are saying those types of things and endorsing those items, what it's really saying is, nobody understands me. Nobody quite gets how bad I am, and I want you to see me. I want you to see the problems I have. Many times, pain patients have basically other healthcare professionals, family members, etc., minimize their issues and say, oh, just get over it. Why don't you just get better? And sometimes that's a wake-up call, and they need to hear that. Sometimes, however, it's just a syndrome that starts to come up where they don't have a physical disability that can be seen per se, and it's not something that's, there's not a real overt mechanism where people can look and say that person's suffering. And so they feel that they need to cry out in any way they can to get this attention. So sometimes that's a bad thing, and sometimes it's just a cry for help. So we do need to pay attention. Now, one of the things that goes along, certainly with depression, and certainly things to look out for, and just the way your patients live their lives and the way they interact with others. We worry about things like distorted thinking. If patients are saying things like all or nothing thinking, the example here is, I still have pain, so I'm not ready for work yet. Meaning, as long as I hurt, I can't do anything. Many times the education for the patient is, you hurt, we want you to be better, we may never take it away. And that's an important point out of pain management in general, is that we rarely get people pain-free. It would be wonderful, but I'll tell you, we're usually lucky when that happens. And so whether it's a surgery, a medication, or physical therapy, it's always chipping away at pain, and we usually have some residual that people will live with. Now, your patients may not have that mindset, and so if they're engaging in all or nothing thinking, they're going to say, well, I'll go back to work when the pain is gone. And again, that may be something that will never happen. Things like fortune telling, saying here's another pain flare, so I'm going to end up in the ER. So issues like that, patients will maximize some of the discomfort they're having, and they'll have a bad experience from the past where maybe they genuinely did go to the ER to get help. However, that's not going to be every situation. I actually have a patient that I work with right now who is coming back, trying to work, but has developed a huge fear of actually sleeping. And part of it was a sickle cell patient, and very, sickle cell patients we could spend a day on, but they tend to get labeled, and some rightly, some wrongly, as problem patients. And this was a young woman I've been working with who finally recalled to me that her worst pain crises in her life, she would always wake up in the morning and she would wake up into a crisis. And those were the times where she developed, pain that would disable her. She would, kind of stayed out of school, wouldn't be able to work, and disengaged from life. Down the road, she developed fortune telling in the sense of, I now associate sleeping with the potential for incredible pain, and so therefore I'm not going to sleep. And patients can really get derailed. That's one simple example, but in many other ways. Down the road, on this graph, which may be a little hard for you to read, and I apologize, one of the things that patients can do is called labeling. Things like you have one bad interaction, and so then you say all doctors are just uncaring jerks. And many times we'll probably see patients who walk in with a chip on their shoulder. Sometimes it just takes a little caring and a little understanding, and give them a couple minutes to vent and say, well, this is going to be different, and we're going to work together. And sometimes we can break through some of those issues. But that type of thinking definitely can set patients astray and make them some of their own worst enemies at times. So the danger of automatic thoughts, basically, they're focusing the attention solely on the pain, and so it's not maximizing what's good about me or how can I overcome this. Their lives focus all on what is this doing to me. It can result in magnifying, again, the perception of pain. Hard to distract these patients, hard to redirect them to other activities and some of the benefits of things like working and some of the gains they can get. And again, can increase feelings of helplessness and hopelessness. Now, here is just a very simple tool that we use with psychology, social work, other disciplines have put to work, where we actually try to train patients how to identify these automatic thoughts. If you think about your life and things that you do, again, we do have these internal conversations that occur pretty much on a consistent basis. When that happens in a negative sense, it's easy to have a downward spiral. So part of it is teaching patients how to break that cycle. If they find themselves getting more depressed or feeling down on a particular day, you train them to find out what's going on right then, identify that thought, write it down, and say, is this real, or what's the level of this, and what is maybe a competing thought that may make sense. It's very simple and can be very powerful for patients. The example here is looking at a stressful situation. The example, if you can't read it, is physical therapy. The emotional reaction you teach patients to write down are things like, well, my back pain, it's getting irritable, I'm starting to be aggravated a little bit. The automatic thought the patient writes down is, this can't be good for me. How could this possibly be a good thing for me to hurt worse? I haven't, I hurt so badly, I haven't seen these people since my MRI, they don't know what's going on with me. The evidence for the thought, like, is there any basis for this? And sometimes there is. And the thought is, well, my MRI shows my spine is falling apart. May or may not be exactly true. And then the evidence, you have the patient write down the evidence that maybe this is a little off track, and then the patient writes in, the MRI doesn't control how much pain I have. Even folks with no pain can have a bad MRI. And that's also a very good thing to remember just in your own lives. Most of us, if we had scans done, have problematic backs that may be asymptomatic for our entire lives. So many patients hold MRIs and those types of films as kind of a badge of courage of, look how bad my back is. And even if they don't have those, they might be suffering quite a bit. So these types of things are very simple. It's a way to kind of push a patient in a new direction and make them start thinking again and make them kind of hopefully adapt new patterns and new thinking. So other things that we can do at various levels, we can work on muscle retraining with patients, doing things like relaxed breathing, progressive muscle relaxation, biofeedback, etc. through hypnosis. Educational groups can be very helpful. You're patients may be resistant to it and think, well, I just need a pill, just fix me and let me go. And that causes the conversation of, we need to do many, many things and attack your pain from many angles. And hopefully they'll be open to that. And if not, we plant the seed for that. We work on cognitive restructuring, like that worksheet I shared with you just a moment ago, and also support groups and family groups. Many things we can do fairly simply to try and help our patients. Now, this slide discusses something that you probably had, or if not, you will have several times, because it's one of the enduring theories to deal with many life changes and behavioral changes with healthcare issues. And that's Prochaska and DiClemente's stages of change theory. Real briefly, it says that patients are not all equal, and they're not all at the same stage of wanting to change their lives. Quite frankly, you may find somebody who's in a pre-contemplation stage. So if you want them to go see a psychologist, you want them to see physical therapy, you want them to, this really started in alcohol cessation and smoking cessation literature, but has since been used in many areas, including pain. So if somebody's in pre-contemplation, they really aren't ready to change, they're not going to tackle tough life issues, they're not wanting to go to PT, they're not really ready to engage. You could spend a lot of time beating these patients up, and they'll fight you, and you won't get anywhere. And so we're going to talk about that in a minute. Contemplation, people start to say, well, yeah, I've been miserable, my back's still hurting, the medicine helps, but it's not great. I'll start thinking about going to PT. Maybe I'll talk to somebody. Maybe. They're not quite ready yet, but we can bolster them a little bit at this stage. Preparation into action. Preparation, again, this started with smoking cessation and setting quit dates, those kinds of things. But for pain management, it really gets applied to, how do I do this? How do I not hurt myself? How do I get active again? Help me out. Give me some education. Action is while you're actually engaging in the behaviors. And maintenance is hopefully they break through, make some changes in life, and are able to sustain them. Now, graphically, how this works. In the pre-contemplation stage, they're not quite in that wheel yet. They're not quite on, not ready to join this little Ferris wheel. And so at that point, like I said, it's not worth beating up patients. Many times what you do is bolster them. You say, well, you may not be ready to talk to a counselor right now, or you might not want to talk to me right now. You may not want to go to physical therapy, but try the medications. We're here for you. You're going to need to do these things down the road, and we'll help you. And then drop it and let them go for a little while. And then that way you avoid the fight. You avoid the fact that they don't put up the barrier that they would have about, you just don't understand me, or it's all just in my head and you think I'm crazy. And so you say, I understand you have pain, but it's complex, and we're here for you. And when you're ready to talk about it, I'll give you some more. Then when they finally get on the Ferris wheel, the idea is you kind of plant that seed, and eventually it starts to take root. They go through contemplation, they think about it, they get ready to change, they make changes. And the thing that's interesting about the stages of change theory, you don't necessarily ever get to the end. You sometimes fall backwards, and that's okay. And this is a cycle. It's a process. Actually, in the smoking literature, where a lot of this developed, we find that on average, smokers take anywhere from 6 to 9 times to eventually quit smoking. So they might be successful for short amounts of time, but it's a very difficult thing to change in life, and it's going to take repeated attempts. And that's fine. Same thing in the pain literature. When you have a pain patient, they may hate physical therapy and not ever want to go back again. But if they keep trying and start learning the techniques, putting them into practice, they start listening to you as their counselor, they may start to get it and start to get better. So realize there's going to be some gains, there's going to be some retreats, but eventually we hope we get to that exit where they maintain that safer lifestyle, and in the purpose of this talk, hopefully get back to work at some level. Now, again, this slide just kind of reiterates some of those last points. The middle section, somebody's in pre-contemplation, give them education, give them some awareness training, and then, of course, back off. The contemplation stage, you really want to be there to help with self-empowerment. You want to basically give them a good attaboy and an attagirl, give them the support they need, get them moving forward. And that's the point where you're really going to become active. And then action and maintenance stage basically help with some of those behavior change strategies that we've discussed to this point. So it's a very useful model. It fits primary health care as well as the kind of multidisciplinary team that is really needed to help these folks, and we can get a lot of gains from it. Now, we also have to make sure that we start anticipating problems that our patients deal with. And let me give you a very simple example. One of the things that's always said, and I do the same thing to patients, we need to be more active. We need you to engage in, whether it's physical therapy, do something at home, do hydrotherapy. You have to be doing something. But when we give that message, if we say, well, you need to lose some weight and your back pain will start to go down as well as the medication use, so they all work together. And if you're more active, you'll be able to get back to work, life will be better. Well, that's nice. However, we haven't set them up for the reality, is that it's going to hurt. They may actually go worse before they get any better. So if we just say, go to the gym, get better, work out, you'll be fine, suck it up, it'll be all right, they may not come back to see us. They may not want to hear those messages, and they may think that we've belittled the problems that they have. What we do find out, when you tell somebody to go to the gym, guess what? If you are physically healthy, inactive but otherwise healthy, no pain problems, no diabetes, no other issues like that, a healthy person goes to a gym. Guess what? For the next 10 to 14 days, you are actually going to feel worse than before you started. How many times do we ever tell our patients that? Say, by the way, I want you to exercise, and you're going to hate me for the next 2 weeks because you're going to feel bad. And at 2 weeks, you're just going to get back to baseline. So doesn't that sound like a good plan that everybody should kind of hop on board for? If we set them up the right way and say, these will be a couple of hard weeks, you may hurt worse, you may wake up more stiff, you may not want to kind of get out of bed, but keep doing it. In 2 weeks, you'll get back to ground zero. After that point, now it's the uphill climb, and things will start to get better. It takes a few extra minutes to be able to talk to the patient that way and to give them that information. But you've set them up with realistic goals and also talked about the barriers that they will encounter. In that way, they're going in with information, and hopefully we'll be able to make those changes. So, in summary, remember that our pain folks are very, very diverse. The problems that they have, even if it's two identical patients in many ways, they're going to react differently, they're going to rate their pain differently. Their lives will be separate. Some of us are able to tolerate great amounts of pain, some of us not so much. And the ability to get back to work, again, going back to one of those early slides, remember, most of our patients are successes, but because they don't need us very often and they get back to work, we don't see them a great deal. And so we get mired down in that 10 to 20% that struggle. And we can't use a broad brush and say that's all of our patients. It's a subset. We need to get better with them. And I think there are several ways we can do that. So keep that in mind, and also with the idea of multimodal treatment. We all play a role, and we have to work together, and I think we can achieve a lot. With that, that's going to end the chronic pain segment with dealing with return to work.